spine now. Since CT has become so popular, you're not going to do as much spine work as I did when I was growing up as a tech, but we still do quite a bit of it. I would say for trauma, it's almost all converted to CT, but for arthritis and other abnormalities, non-traumatic injuries or chronic type things, we still can be asked to do quite a bit of spine imaging. So I'll start out with the open mouth, although if I was doing this series, I would probably do the AP first, but I'm going to show you the open mouth first. The collimation for this is quite tight because really we're just collimating just to the around what will eventually be his open mouth, and so it's pretty small collimation. I would say 4 by 4, and I've placed my right marker just inside the field of view. In order to decide how this projection is going to center his atlas and axis in the center of his open mouth, I have to look at what they call the occlusal plane. So I'm going to draw an imaginary line from the bottom of his upper teeth to the mastoid tip, which is right behind his ear. Now this is nice because you can see a laser light here. So I'm going to ask him to just open his mouth slightly. Now this is just so I can see the top of his teeth. Then I'm going to feel for the mastoid tip, which is that bump that you can feel right behind your earlobe. And I'm going to line up the bottom of his teeth with his mastoid tip. Now the position that his head is in right now, I feel like is a good position for this patient. Sometimes you need to rock back a little bit, sometimes you need to tuck down a little bit. It's just until you get the occlusal plane lined up. And then from this point, I'm going to place my hand on his forehead and ask him to open his mouth as wide as he can. My occlusal plane is still perpendicular. And now I'm going to see his atlas and axis centered in the center of his open mouth. So I'm centering to the center of his open mouth. Okay, you can relax. But his occlusal plane is what's perpendicular. Read over this section in your textbook for a little bit more detail. And as you can see, that's not an easy position for a patient to maintain for any length of time. So you're going to want to be completely set up for this. Get your occlusal plane perpendicular, make sure your collimated marker's on, shielding is on, everything is set to go. And right before you go to take the exposure is when you're going to have them open their mouth. The book recommends that you also have them phonate, which is say, ah, because it drops the tongue out of the way. I've never seen a technologist do that. But the purpose of it, should it be on your test or on the ARRT, the purpose that you have them phonate is to drop the tongue out of the way, because it is a density. It's a pretty thick muscle, and so it just gets it out of the way. So that is our AP odontoid open mouth. That's what they call it. We're going to review this again when we talk about trauma spine work, but for now, that's how you do the odontoid. And then moving on to the AP cervical. This is a 15-degree cephalic angulation, 10 to 15. So I'm going to drop to 37. Okay. This is 8 by 10 collimation. So on a 10 by 12, 1 inch on the sides, 1 inch on either end, my right marker, sure that and you'll notice that for the last two, or this projection and the one I just did, the open mouth, he doesn't have a pillow. That creates density, and so for your cervical x-rays, you have to remember to take the pillow out. So I'm going to make sure that his mid-coronal plane is straight. I'm going to elevate his chin just a little bit because what I want to do is get the mandible out of the way. But I don't want to rock his head so far that I get the back of the head in the way either. So it's really just until the plane of his mandible is about perpendicular to the table. So raise your chin just a little bit more. Okay, plane of his mandible is perpendicular. And I'm roughly centering at the thyroid cartilage, which is his Adam's apple. It's also about the level of C4. So as it's passing through, it's hitting C4 and exiting. And the reason we've got the curve is because the cervical spine has a lordotic curve to it, and as it curves, I'm trying to match that curve with my central ray. So that is my AP cervical. My patient shielded. I would have him stop breathing and expose. Okay, we have him set up now for a lateral projection. When we get to trauma later in the spring, I'll show you how to do a cross table lateral. But for the upright, which is recommended because the shoulders are going to be in the way, doing him vertical or standing up allows him to depress the shoulders a little bit. You could have the patient hold weights. I'm not going to demonstrate that here because I'm also going to show you how to do a swimmer's view standing. So what I want to do, I have it 10 by 12, opened up to a 10 by 12. I'm going to put the top of my IR about 1 inch above his EAM. That stands for external auditory meatus. So the upper border with his ears, I'm going to put about level with the top of his ears is where I'm going to have this be. I'm going to elevate his chin because I want the back of his mandible to come off his first two cervical vertebrae. If he left his chin down, his mandible would cover that up. So I'm going to have him raise his chin. I raised my buckies, so I'm going to adjust my central ray up, and we're going to be aiming roughly at C4, which again is going to be about the level of his Adam's apple. Okay, and I want to be on his mid-coronal plane, so take just a small step forward. You want to make sure that his left side is up against, left or right side is up against the wall bucky. His feet are spread apart a little bit for balance, and where his mastoid tip is roughly his mid-coronal plane. So if you have him centered on the mastoid tip, you're roughly right mid-coronal plane. I want to make sure I have light in the back, light in the front. I'm going to place my marker. I would place it down lower in the middle. Here's a good spot because I know his anatomy is not overlapped in any way. I'm going to have you take a breath in, blow it all the way out, hold it out, and I would expose. I'd have a shield in front of him, and that is our lateral cervical spine. Okay. If I looked at this image and I did not see the C7-T1 junction, I would do a swimmer's view. There's a few different ways to do this. We'll talk about it more when we talk about thoracic spine, but in conjunction with a C-spine, I would have him raise his left arm above his head. His right arm is now below, and what we've done is taken the humeral heads and separated them. So now I should be able to see over the top of his right shoulder and underneath his left shoulder and see the C7-T1 junction. I'm going to do this at 40 inches. And then if I needed to, I could put a slight caudal angle if I felt like his right shoulder was still in the way. It's going to be centered at C7, T1. If I'm at C4 right now, 5, 6, 7, I would want to drop it a couple of inches from that. So I'm pretty much coming in right, skimming the top of this shoulder, still on mid-coronal plane, and my collimation is, it can still be 8 by 10, but because I came into 40 inches, it looks a lot smaller. Okay. The book talks about tight collimation on this, but doctors like to be able to count down. So I would leave it open to an 8 by 10. And that's, if you didn't see C7, T1, you could do what they call a swimmer's view. Before I demonstrate on the patient, I wanted to show you in effect what we're trying to do with the obliques. It's to open up the cervical foramina, intervertebral foramina. The way they sit in the body is demonstrated by the straw, okay? They are located about 45 degrees out from mid-sagittal plane, and in the AP position, they're down about 15 inches. So if I was going to see through this hole, I would have to oblique the patient 45 degrees, and I'd have to take my central ray and angle 15 degrees cephalad. And now my central ray will pass directly through the intervertebral foramina. If I was doing PA obliques, okay, I would have to rotate the patient 45 degrees, and now I'm going to angle 15 caudad, and now you can imagine that the pen is exiting through that straw. So what we're trying to do is position the patient and the central ray to open up how the intervertebral foramina are positioned. So when they're PA oblique, you're looking at the foramina that's down, and I'm angling caudad. When I'm doing AP obliques, I'm looking at the foramina that's side up, and I'm angling up. Okay, side up, angle up, side down, angle down. All right, I'm going to demonstrate anterior obliques first. Some clinical sites are going to keep this at 72 inches. I think the book recommends that you come into 40. Anytime you're out at 72 inches, there has to be a good reason for that other than it just being convenient for you. 40 inches is less dose to the patient, so because you have to use more mass at 72 inches than you do at 40. So I have a 10 by 12 lengthwise in the bucky. I put my right marker because he's RAO. I'm going to position him, back up please, angling my patient 45 degrees, and his head remains lined up with his body. At the clinical site, you may see techs turn the head lateral, but what that does is twist C2 on C1, and it can actually close the vertebral foramina. So it's best if you keep the entire mid-sagittal plane together. So head is straight, patient is angled 45 degrees. I have a 15-degree caudal angle. Now normally the patient was on the table, I would adjust my SID because of this, but most upright wall buckies are detented at 40 and 72, and they don't allow you to adjust your SID after that. So I'm going to keep this at 40, angle 15 caudad. I've got the upper border of the film. I'm starting about the level of his ear there, and at 15 caudal, I'm ending about right here at the EAM, but it's projecting his spine downward, and so it looks like I'm entering a little bit low here, but it'll be positioned fine once that projection carries the image down. So he is in an RAO position. I'm going to see the foramina closest to the IR, so I'll be viewing the right foramina on this one. So that is our REO. I would shield, I would have him suspend breathing and take the exposure. Now I'm going to do the AP oblique that shows the right foramina as well. So if you can turn around, face the camera. So if I'm showing the right foramina again, now I'm viewing the side up. So I would have him at 45 degrees and I'll be viewing his right foramina, but I have to move my marker because now this is his right side. I'm going to move the right marker over here and I'm going to change the degree of my angulation from caudad to cephalad. 90 would be about 105 because we're going 15 degrees beyond 90. Place your arms along your side for me. Come forward just a little bit. Okay. Now you have to compensate for the angulation. So it looks like I'm starting really low, but by the time it's actually passing through at the level of his spine, I'm at C4. And then it comes up, and so I adjust my bucking. So his mid-sagittal plane is lined up. He's rolled 45 degrees. I've got light in front, light in back. I've got my right marker. You could either put your right marker on that side or your left marker on this side. Since he's in an LPO position, I could do that. Really doesn't matter. That's up to the clinical site. I would shield, have him suspend respiration, and expose. And on this one, we are seeing the foramina furthest from the film. In this case, it would be the foramina on the right side of his vertebral column. If I had him in an RPO position, I would be looking at the foramina on the left side of his vertebral column. All right, so that is cervical spine.